About the case, it's a lady who had a colonoscopy 10 years ago with the removal of 2 or 3 low-risk polyps. Lost to follow-up, but she had a IFOP 10 years later. So now, when she is positive, and she is quite a large lady. So she's an obese patient. So I had a difficult time with this patient, and it was not what I expected. It was especially the splenic flexure. But to begin, I had a bit of an angulated sigmoid. I think it was due to the hysterectomy, but that was actually
7 minutes. Is it?
1 minute.
1 minute. Sorry.
So it was a bit angulated, but I managed that. I think with not too much difficulty. The patient was also sedated, so she was not conscious, which I think was a bit of a shame because I couldn't have feedback, especially around the splenic flexure.
So you've rotated so far that that transverse colon has can now come right back on itself. So
it's outside the descending colon.
It's outside the descending colon. You need to go back across the midline. So it's always going to cause a problem because the amount of resistance involved in that is huge. Now, we don't normally apply torque at this point in time, generally, if it's relatively straight. But in this occasion, anti-clockwise torque here, Xander, will reorientate the transverse colon and drag it across the midline and afford less resistance. The other thing you could possibly do is to roll the patient on the right-hand side, which would open up the fold, and the gravity would then affect the transverse colon and effectively pull it down. So instead of it going off to the right, it would then go off to the left, and it makes your insertion a little bit easier. So should we see what happens?
Yeah. But I think this is still at left lateral. So, no, we didn't.
No, on supine.
No,
so there it's going across the midline. Can you see that?
Yeah.
And if you, so as you are progressing there, I would be encouraging you to apply anti-clockwise torque, which would do 2 things. It would drive the tip forward, it would flatten the transverse colon, it would bring the splenic flexure forward and more in alignment with the colonoscope. Yeah.
And I was actually, when my actual trouble, and probably it's caused by this wrongful movement, the splenic flexure is getting really, really, really large.
So what I want you to understand, Xander, is when you have a problem, it's often multiple problems. So you have multiple problems here. So you've got an acute angulation at the tip of the instrument. That isn't a problem. That is an advantage because that gives you a hook. So you need the angulation at the tip. The next thing is that you've got a slight bore in the transverse colon. Right, that's going to dip down. And then the third problem is you've got a high-riding splenic flexure which rotates posteriorly. And as you insert, because of the bore in the transverse colon, it exacerbates the problem at the splenic flexure. So you have to have in your head a problem-solving algorithm which solves the first problem first and the second problem second. So where you need your pressure is actually in the midpoint to lift the transverse colon up, and then you can reduce the splenic flexure. Okay, so you did a push through, but the solution to this problem here, Xander, is to put pressure in the right upper quadrant below the rib cage, exactly where David's putting his arrow there, yeah? And then you pull the scope back, and then you pull the scope back.
Pull it back?
Yeah.
Okay.
While pushing on the right upper quadrant.
Correct.
The right upper quadrant.
Yeah, left upper quadrant or right upper quadrant? Right.
Yeah, it's in the right upper quadrant. The reason being is as you push the scope in, the transverse colon is fairly redundant and pushes laterally. And your loop, if you go back for a few frames, the loop as it forms pushes out. It pushes outside the line of the ascending colon. Do you see that?
Yeah. No, I do. Yeah.
So as you're reducing it, as the loop's going to reform, it's going to reform in the same place. So the pressure needs to be to the left of the midline if you're looking down on the abdomen in the AP position of patient supine. So left of the midline pushing up towards the right upper quadrant, and then you straighten it. And then as you insert, once you've straightened it, As you insert with anti-clockwise torque, and it will bring your splenic flexure forward. So you solve one problem, and then you move on to the second one, or you just push through the whole loop.
John, I don't understand what you're saying, so potentially other people watching will not understand what you're saying. So can you just go through that again? Because I think that's actually a critical point here.
I'll do it on the whiteboard, David. I'll draw it.
Yeah.
I'll draw it, because this is not uncommon.
Because it's actually counterintuitive, because when you see the scope guide, what happens is the splenic flexure becomes huge. So, well, my mind at least tried to fix that problem.
And support the transverse, maybe.
Maybe support the transverse, yeah. But in fact, it's because there is resistance caused in the proximal transverse due to the angulation.
Yeah. Okay. So your problem really is this splenic flexure is hugely variable, and it keeps rotating posteriorly. So if it rotates posteriorly, what happens is this comes this way. It swings right across because this is swinging in this direction. Can you see that? So your tip.
These are AP.
AP views. Yeah. So your tip here, as this rotates posteriorly, this rotates anteriorly. So the tip goes from here to here, and then the rest of your colon is now across here like that.
Yeah.
That's the first thing, right? So this is always likely to occur, and also you've got a high riding splenic. So this is the shape it's trying to form as you push in here. If there's resistance here, and as you increase the loop, and as you rotate posteriorly, your tip comes backwards, not forwards. You're always struggling, right? So you managed to solve a little bit of that. So we go to the next problem you had. And the next problem you have is you've got a high riding splenic, and it comes across, and you had this sort of shape.
Yeah.
And as Roland points out, the colon's here. And to resolve this, if you pull back, the first thing that comes down is this. This doesn't rotate initially. So when you first pull back, it's the splenic loop that comes down. And then you need to apply clockwise torque to the scope to lift what is this part of the transverse colon to this position. So you rotate clockwise to lift it up. Okay? So as you pull back, your scope goes from this position
Question mark, yeah.
to this position, because you've done two things. You pulled back
Rotated clockwise.
and you rotated clockwise torque. Now, in doing that, because you're applying clockwise torque, you're pushing the splenic flexure back. So when you get nice and straight, you've got a little bit of redundancy because your scope is actually in this position. It's rotated posteriorly with the clockwise torque. So then what you need to do is you need to put pressure here to stop this reforming. And the pressure we normally see goes in this direction and this direction, but actually probably pushing this back across the line to stop this from reforming. So actually this is quite a long transverse colon. So I would normally put, if this is the abdomen here, I would probably put the flat of my hand from here to here, and I would probably push like this, lift it up. And when you lift it up, it will stop this bit reforming, and then you can insert with anti-clockwise torque. And as you do that, you bring this forward, it shortens the scope, and it drives you in. It stops you going to a long scope position.
Yeah.
Does that make sense?
Absolutely.
It does. A very nice explanation, John. Thank you very much. Other stuff from this video, just the polyp maybe, because we're just waiting for Louisa to come. I think this is an interesting thing. Always interesting to see polyps for me. So there was one. That was one, right? There was another one, right?
Two small ones. But that was the large one. Now it looks like it's been draped over a fold, but this is just the other. But I'm not sure if it's on this video.
1 second, I need to screen share with these guys because we're not seeing anymore. So this was the polyp.
Yeah. So you want like a classification or
Why don't we go for a classification? I always want a classification. Yeah.
So to start with the blink, I don't have really a bad blink.
Okay.
It's granular, which is good.
Wait a minute. Do we go straight to granular? What's the after blink?
I'll give you a clue.
Paris,
Demarcation, say.
well, yeah, demarcation. I didn't really have a demarcation zone, so the disclaimer: there's a large, area of the polyp behind that fold you saw. So it was actually quite large in diameter, and there were no demarcation zones.
Okay.
It was an 2A polyp.
How big do you think it was?
I think it was about 25 millimeters when you put it completely.
It's quite big, isn't it? Yeah.
No demarcation zones, and actually all regular pit pattern.
Okay. So what do you think the risk of submucosal invasion is then?
I think it was low.
Okay.
Really.
Something like
very low.
2.5% or something. Okay.
Paris classification.
2A.
I'm struggling to find the polyp. I'm sorry.
10 millimeters, isn't it? So by definition, it's an LST. It's a lateral spreading tumor.
And Zander, I mean, so my first question is: should we remove this endoscopically?
Yeah, sure.
Should you remove this endoscopically today?
Not without supervision. I'd like to be diplomatic about it.
Okay, but should anyone remove this today without the patient's asleep, right?
The patient was asleep.
So should anyone remove that without a discussion with the patient?
It is left. It is the cecum is also a bit folded up on itself, so it is quite low. So probably there is a risk of perforation. So it has to be discussed.
I mean, this is 25 millimeters. There's certainly a risk of perforation, delayed bleeding, all of that stuff.
Yeah.
I mean, it's a local thing. It's, of course, if you know the patient, if you discuss it up front, okay. I think the majority of cases, for this sort of thing, consent is the issue.
Yeah.
Do you have consent to do it? I take the point that bowel prep and everything, and the patient has to come back and whatever. But I mean, this is how long is this going to take you?
Half an hour.